Looking to elevate your COMLEX prep? Dive into RemedyOMM.com. Discover our comprehensive question bank, expert lectures, and personalized consultation services, all tailored for your success. Join the community of achievers. Visit RemedyOMM.com today and take the next step in your medical journey.
Hello everybody, welcome back to Remedy OMM. Today, we will be going over one of the most difficult topics in osteopathic medicine, cranial diagnoses and treatment. Now I know this isn't everybody's favorite topic, but we did our best to make this lecture as easy and simple as possible to maximize high yield points and teach you everything you need to know to do well on test questions. In this lecture, we will go over the various diagnoses associated with cranial practice and any associated treatments. In order to diagnose and treat cranial dysfunctions, we first need to understand the anatomy, which can be reviewed in Part 1. Diagnosing dysfunctions requires one to know the vault hold. The vault hold is one of the highest yield things to know regarding cranial questions on COMLEX exams. Specifically, knowing where each finger goes is key. Here is a list of where each finger is supposed to be. Internalize it, memorize it, it's the key. You can diagnose cranial dysfunctions by comparing the landmarks on one side to the other. For example, if your index finger sits more superiorly on the left than the right, then that tells you that the greater wing of the sphenoid is more superior on the left side. This information, along with comparison of the other landmarks, will give you the diagnoses. In addition, sphenobasilar strains are treated with the vault hold technique, so knowing the vault hold is key to acing cranial board questions. Here's a visual of where the fingers go. You can see the thumb up on the frontal bone but not crossing over the midline. You can see the index finger, labeled D2 for digit 2, on the greater wing of the sphenoid. The middle finger, labeled D3 or digit 3, is on the zygomatic process of the temporal bone. The ring finger, or fourth digit, is on the mastoid process, and the pinky, or fifth digit, is on the squamous suture of the occiput. This is the vault hold. The first diagnosis is a sphenobasilar torsion. In a torsion dysfunction, we have the sphenoid and the occiput rotating to opposite sides on an anterior to posterior axis. These dysfunctions are named for the side with the more superior greater wing of the sphenoid. These can be caused by trauma. Now, when assessing a patient in the vault hold, what you'll observe is that on one side, your index finger will be more superior than the index finger on the other. And on the other side, you'll observe that your pinky is more superior than the other. Let's take a look at a visual example. Here we can see a picture of a right torsion. You can see the black line cutting through the middle, which represents the anterior to posterior axis. The sphenoid and occiput rotate opposite to each other about this axis. In this example, we can see the greater wing of the sphenoid on the right is more superior than the left, and we name the torsion based on the side with the more superior wing of the sphenoid. So in this example, when performing the vault hold, you'll notice that your right index finger will be more superior than the left, and you'll notice your right pinky or fifth digit will be more inferior than the left. This physical exam information tells you that the patient has a right torsion, and of course the opposite would be true for a left torsion. Next, we move on to side bending and rotation. Side bending occurs when the sphenoid and the occiput rotate in opposite directions about two parallel vertical axes. Rotation occurs when the sphenoid and occiput rotate along an anterior to posterior axis towards the same side. This dysfunction is named for the more anterior wing of the sphenoid. On vault hold, you'll notice that on one side, your index finger and pinky finger are further apart when compared to the other. I know this sounds confusing, so let's take a look at a visual example. The next dysfunction is a lateral strain or lateral shear pattern. For this dysfunction, you want to focus on the direction that the base of the sphenoid moves. This movement pattern occurs again on two parallel vertical axes, where the sphenoid and occiput are rotating towards the same side. Let's take a look at a visual. The next dysfunction is a lateral strain or lateral shear pattern. For this dysfunction, you want to focus on the direction that the base of the sphenoid moves. This movement pattern occurs again on two parallel vertical axes, where the sphenoid and occiput are rotating towards the same side. Let's take a look at a visual. Here we see the sphenoid on the right and the occiput on the left. The two rods represent the two parallel vertical axes. The orange arrows represent the rotation, and you can see that the two bones are rotating towards the same side. In this example, you can imagine how the two bones rotate. The base of the sphenoid would be to the left, therefore making this a left lateral strain. A lateral shear is a variant of a lateral strain and is depicted here by the green arrows. In a lateral shear, there is no rotation, but instead lateral translation of the sphenoid and occiput. In this example, the green arrows show the sphenoid translating to the left, while the occiput translates to the right. Since we named the dysfunction for the movement of the base of the sphenoid, this would represent a left lateral shear. On the volt hold, these lateral strain patterns can seem complex. The lateral strain and shear patterns will give the observer a parallelogram shape. It's complicated to describe through audio and pictures alone, but if you practice with the shadow hands, like in this picture, you'll notice that the left lateral strain pattern will give you the parallelogram shape leaning towards the right. However, a left lateral shear pattern will give the user a parallelogram leaning towards the left. When it comes down to board questions, pay attention to hints about translation, which will clue you into a shear pattern. Let's move on. I promise it's all downhill from here. A vertical strain pattern occurs when the sphenoid and occiput rotate along two parallel axes. Again, these dysfunctions will be named for the movement of the base of the sphenoid relative to the occiput. And here we have two types of vertical strains, superior and inferior. In this picture, we can see the normal positioning of the sphenoid and occiput on the right. In the middle, we see the displacement of the base of the sphenoid more superior compared to the occiput, which occurs because of rotation of the two bones. On the right, we see the opposite, where the displacement of the base of the sphenoid is more inferior compared to the occiput. Lastly, we have compression, or SBS compression. This occurs when the base of the sphenoid is compressed into the base of the occiput, and you will observe restrictions in both flexion and extension. The key to SBS compression is knowing that the cranial rhythmic impulse, the CRI, is markedly decreased. Recall that a normal CRI ranges from 10 to 14, and in SBS compression, you'll observe a CRI of less than 10. Another high-yield fact to know is that if someone has SBS compression, you treat with the CV4 technique, also known as bulb decompression. And for completeness, here's a list of both relative and absolute contraindications to performing cranial techniques. I know that was a lot. Thank you for sticking through to the end. That's all I have for you guys today. I'm going to link two great cranial videos from Osteopathic Clinical Skills channel. I highly recommend you watch and review them. Please like, subscribe, and support our channel. If you have any questions, please don't hesitate to comment below. We will see you guys in the next lecture.